Hi, good morning, doctors. Today we are on our 30th day of reading Oxford Handbook of General Practice, and I'm Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. So let's start reading today. We are at page number 544, chapter 15, Neurology, Spinal Cord Conditions. Spinal cord injury tends to affect young people, especially young men. It is a devastating, and the GP and primary care team are vital part of ongoing support network. Causes are trauma, 42% falls and 37% of road traffic accidents, herniated disc, transverse myelitis, tumor, abscess, quadriplegia and tetraplegia. Caused by spinal cord injury above the first thoracic vertebra, usually results in paralysis of all the four limbs, weakened breathing, and an inability to cough or clear the chest. Paraplegia occurs when the level of injury is below the first thoracic nerve. Disability can vary from impairment of leg movement to complete paralysis of the legs and abdomen up to the nipple line. Paraplegics you have full use of the arms and hands. Incomplete spinal cord injuries. Anterior cord syndrome. Damage is towards the front of the spinal cord, leaving the patient with loss or decreased ability to sense pain, temperature, and touch sensations below the level of the injury. Pressure and joint sensation may be preserved. See, posterior columns are meant for pressure and joint sensation, whereas anterior columns are meant for the pain, temperature, and touch perceptions. So, when there is anterior cord injury, there is decreased ability to sense pain, temperature, and touch, whereas pressure and joint sensation can be preserved. Central cord syndrome. Damages in the center of the spinal cord typically results in loss of function in the arms, but preservation of some leg movement plus or minus some control of bladder bowel function. So damage to the center part of the spinal cord. And so there is preservation of some leg movement or some control of bladder and bowel function, but loss of function in the arms. Posterior cord syndrome. Damages towards the back of the spinal cord typically leaves the patient with good muscular power, pain, and temperature sensation, but difficulty in coordinating the limb movements because of loss of pressure and joint sensation. Brown-Sequard syndrome. Damage is limited to one side of the spinal cord, resulting in loss or decreased movement on the injured side, but preserved pain and temperature sensation on the same side, and normal movement on the uninjured side, but loss of or decrease in pain and temperature sensation on the opposite side. That's because there is crossing over of the uh, nerves from one side to the other at the level of the spinal cord for that part of the body. So, whenever there is one side unilateral damage to the spinal cord, it results in decreased movement on the injured side. Motor function is lost on the injured side, but sensory function is preserved, whereas sensory function is lost on the opposite side, whereas motor function is preserved on the opposite side. Cauda equina lesion. The spinal cord ends at L1, L2, at which point a bundle of nerves travel downwards and through the lumbar and sacral vertebrae. Injury to these nerves causes partial or complete loss of movement and sensation. There may be some recovery of function with time. The spinal cord ends at L1, L2, at which point a bundle of nerve travel downwards towards the lumbar and sacral vertebrae. Injury to these nerves causes partial or complete loss of movement and sensation. There may be some recovery of function with time. Transverse myelitis. Inflammation of the spinal cord at a single level. Symptoms develop rapidly over days or weeks and include limb weakness, sensory disturbance, and bowel and bladder disturbance, back pain, and radicular pain. So, almost all the problems associated with spinal cord compression. Transverse myelitis. Recovery generally begins in less than 3 months, but it's not always complete. Causes of transverse myelitis are idiopathic, thought due to autoimmune mechanism, infection, vaccination, vascular, thrombosis of the spinal arteries, vasculitis secondary to heroin misuse, spinal AV malformation. Autoimmune diseases like SLE, Sjogren's syndrome, and sarcoidosis. Multiple sclerosis and malignancy. These are the causes of transverse myelitis. Management. Depending on severity of symptoms, admit as an acute medical emergency or refer for urgent neurological opinion. Syringomyelia. Tubular cavities, syrinxes, form close to the central canal of the spinal cord. As the syrinx expands, it compresses the nerves within the spinal cord. Most common in patients with previous spinal injury, although many may be years before. Typically presents with wasting and weakness of the hands and arms and loss of temperature and pain sensation over the trunk and arms, that is the cape distribution. There will be waste. This is upper limb problem, syringomyelia. Wasting and weakness of the hands and arms, loss of temperature and pain sensation over the trunk, the arms, over the cape distribution. Refer to neurology if suspected. General principles of rehabilitation, page 196. Common neurological rehabilitation problems, 554. Specific problems associated with spinal cord injury. We will see now. Autonomic dysreflexia, hyperreflexia, reflex sympathetic overactivity causing flushing and raised BP may be severe. Only occurs in patients with lesions above the T5 T6, usually triggered by discomfort below the level of the lesion. Presentation is with pounding headaches, sweating, flushing, or mottling above the level of the lesion. So, what is the presentation of autonomic dysreflexia? Pounding headache, sweating, flushing, or mottling above the level of the lesion. Sit the patient up, remove any obvious cause, pain, distension, bladder distension, constipation. Give a GTN spray 1 to 2 puffs sublingual or nifedipine 5 to 10 milligrams capsule broken sublingually. If not settling, admit to the hospital. So for autonomic dysreflexia also you need to give GTN spray or nifedipine 5 to 10 milligrams sublingually. Loss of temperature control. Most people with complete spinal cord injuries do not sweat below the level of the injury, and many quadriplegics cannot sweat above the level of the injury even though they may sweat due to autonomic dysreflexia. With loss of ability to sweat or vasoconstricts, careful control of environmental conditions is essential to avoid any hypothermia or overheating. In hot weather, advise cooling with wet towels. Infertility. Many male patients suffer from infertility due to failure of ejaculation, retrograde ejaculation, thermal damage due to sitting in a wheelchair, poor quality sperm, chronic infection of prostate or seminal vesicles, which is common. Refer for a specialist advice. Bowel and bladder function. Both bowel and bladder function are reflex actions that we learn to override as a children. If the lesion is above the level of this reflex pathway, that is T12 for bowel and T6 for bladder function, then automatic emptying will still occur when the bladder is bowel or bowel is full. So T12 is for bowel function and T6 is for bladder function. The reflex arc of this function is below at this level, and if there is a lesion above this level, then the automatic emptying will occur when bladder or bowel is full, though there is no control. If the lesion is below the level, there is no emptying reflex. And so, if the lesion is above that particular level, there will be no control. If the lesion is below this level, there will be no emptying reflex. Bladder and bowel care programs reflect this. Useful leaflets are available from the Spinal Injuries Association. Spasticity, page 555, pressure source 585, UTI 555, depression 173. Page number 546, epilepsy. Epilepsy is a group of disorders in which the fits or seizures occur as a result of spontaneous abnormal electrical discharge in any part of the brain. They may take many forms but may usually take the same pattern on each occasion for a given individual. Prevalence 5 to 10 per thousand. Okay. 5% of those more than 21 years old having their first fit have a cerebral pathology. 10% if aged 45 to 55 years. So as the age is increasing, there is some cerebral pathology, or that there is some organic cause for epilepsy. Transient loss of consciousness, page 524, epilepsy in children, 876, management of a fitting patient or status epilepticus, 1080, management after the first fit. So when there is a first fit, 60% of adults who have one fit will never have another. 90% of EEG will be normal. So after a first fit, whether you have to manage them or not, because 60% will never have a second fit, 90% EEG will be normal. So refer all the patient with a first suspected seizure for assessment by a neurologist with training and expertise in epilepsy urgently to exclude any underlying causes like tumor and receive a clear guidance on medication, work and driving. So, but every case of epilepsy on the first fit, they should be referred to a neurologist. Classification of seizure types. It's important as this has an implication for management and prognosis. Partial seizures limited to one area of the brain only, termed simple if no impairment of consciousness, and complex if consciousness is impaired. Partial seizures may become generalized sometimes. Generalized seizures, whole brain is involved. Consciousness is usually but not always impaired. Six major types are there of generalized seizures: tonic-clonic, grand mal seizures, absence or petit mal seizures, myoclonic seizures, tonic seizures, clonic seizures, and atonic seizures. Some people have seizures that cannot be classified in this way. Todd's palsy, focal CNS signs, example hemiplegia following an epileptic seizure. So, Todd's palsy is focal signs after an epileptic seizure. The patient seems to have had a stroke but recovers within 24 hours. Causes of epilepsy in adults. A cause is found in more than two-thirds of the people with epilepsy. The most common causes are cerebrovascular disease, cerebral tumors, genetic or congenital or hereditary conditions, drugs, alcohol or other toxic causes, head trauma including surgery, post-infective causes, meningitis or encephalitis. So, CVA, cerebral tumor, genetic congenital hereditary conditions, drugs, alcohol, toxic causes, head trauma, including surgery, post-infective causes like meningitis or encephalitis can also cause seizures. Assessment of seizures. Table 15.10, we will see that. Screening for depression, 173. Long-term management of epilepsy, 548. Epilepsy and pregnancy, 807. Driving in epilepsy, 548. Mortality. The death rate is increased 2 to 3 times. Deaths are related to underlying condition, accidents, SUDEP or status epilepticus. SUDEP meaning sudden unexplained death in epilepsy is SUDEP. Probably due to central respiratory arrest during a seizure, decrease risk by optimizing seizure control and being aware of potential consequences of nice seizures. Summary of points to cover during assessment. Summary of points to cover during assessment of epilepsy. Background. If there is a previous head injury, alcohol or drug abuse, meningitis or encephalitis, previous stroke, febrile convulsions, family history of epilepsy. Provoking factors. Whether sleep deprivation, alcohol withdrawal, flashing lights are provoking the attack of epilepsy. Prodrome or aura. Is there any prodrome that precedes the fit? May it be a change in mood or behavior noticed by the patient or others. Aura, a part of the seizure that precedes other manifestations, odd sensations like deja vu, odd feeling of having experienced that time before, strange smells, rising abdominal sensation, or flashing lights. Features of an attack. Eyewitness report. If available, The color of the patient, the movement, the length of the fit, the circumstances, after effects, memories of the patient of the event and the first memories after the event, attack frequency, relationship to sleep, menses, etc. Residual symptoms after an attack. There's a bitten tongue, incontinence of urine or feces, not specific for epilepsy, confusion, headache, aching limbs or temporary weakness of the limbs like Dodd's palsy. Examination, neurological examination, fever, photophobia, neck stiffness or a petechial rash, any residual focal neurology, signs of increased ICP, increased intracranial pressure. General examination, BP, heart sounds, heart rhythm, rate, signs of systemic illness. Investigations, first fit only. When it's a first fit, you have to check an ECG, you have to do a capillary blood glucose, maybe due to hypoglycemia he had a fit. Blood, urea and electrolytes, you have to check for electrolytes, creatinine, EGFR, LFTs, calcium, FBC, ESR, CRP and HIV. Differential diagnosis. Syncope, simple or situational, can be a syncope, situational or simple syncope. Psychogenic non-epileptic attacks, pseudoseizures, tics, panic attack, hypoglycemia, normal phenomenon like deja vu, cardiac disorders, example arrhythmias, aortic stenosis and HOCM, TIAs, migrainous aura. Avoid prescribing sodium valproate to girls of childbearing age if essential ensure pregnancy prevention plan is in place and that the information is provided about potential teratogenic effects both verbally and in writing. Management of epilepsy. Education. Epilepsy is a diagnosis causing alarm and fear. How much does the patient and family understand about epilepsy? Acknowledge the distress and answer the questions. Provide information on what epilepsy is and support a viable locally and nationally. What to expect. Fits are controlled with drugs. In 80% cases, concordance with medication when the drug withdrawal may be considered. What do you do during an attack? Work, inform the employer. Do not work at heights or with near danger machinery. Avoiding risk. Avoid cycling in traffic. Only swim if a lifeguard is present. Driving. Inform the DVLA and motor insurance company. Single unprovoked seizure. Group 1. Stop driving for 6 months. Group 2. License restored if no seizures for more than 5 years of medication. So if you are a group 2 driver, then your license will be revoked and will be restored only if there is no seizure for more than 5 years. If you're a group 1 driver, one single unprovoked seizure, stop driving for 6 months. Epilepsy or multiple unprovoked seizures. If you are a group 1 driver, stop driving until fit free for more than a year. Group 2 license is restored if seizure free for more than 10 years of anti-epileptic medication. So group 2 driver, if you want to drive, you have to be on medication and your seizure should be controlled for at least 5 years of your medication or 10 years of your medication if it's multiple seizures or unprovoked. Drugs, table 5.11, treatment usually starts after the second seizure. So in the first seizure, you never start the medication unless there are some conditions. So usually starts after the second seizure. Drug of choice is a specialist decision. Patients can claim free prescriptions. Withdrawal of drug therapy. Consider if fit free for more than 2 or 3 years. Decision to stop must be the patient's. Balance problems or inconvenience of drug taking against risk of fits. Refer to neurology for supervision of drug withdrawal. If adult with grand mal epilepsy, 59% stay fit free for 2 years. Seizure recurrence is more likely if generalized tonic-clonic seizures and myoclonic epilepsy or infantile spasms. Taking more than one drug for epilepsy, more than one seizure after starting treatment, duration of treatment more than 10 years, fit free less than 5 years. So these are the risk factors for recurrence. Seizure recurrence more likely if it is a GTCS, myoclonic epilepsy, infantile spasm, or if you are taking more than one drug, more than one seizure after starting treatment, or duration of treatment was 10 years, or fit free less than 5 years. Patient must stop driving during medication and withdrawal and for 6 months afterwards. Other treatments, surgery. Used for intractable partial seizures, hemiepilepsy, epilepsy with focal EEG or radiological features. Vagus nerve stimulation decreases the frequency of seizures for those refractory to anti-epileptic medication but not suitable for respective surgery. Ketogenic diet. Effective in some patients with refractory epilepsy, take a specialist advice. At annual review, review a care plan, record the fits and precipitating causes, check the drug concordance, frequency of repeat prescriptions, and side effects. If fit free more than 2 years, discuss withdrawing the medication. If females of reproductive age, give a contraception. Preconception advice. Refer for a review by a neurologist if control is poor or drugs are causing unacceptable side effects. Seizures have continued despite the medication for more than 2 years or on two drugs. Pointers to a previously unsuspected cause for the fits appear. Concurrent illness, physical or psychiatric, complicates the management. For pre-consumption advice or to discuss withdrawal of medication. Okay, this table describes the drugs used for epilepsy. Yeah, that's the table. Table 15.11. Commonly used drugs in epilepsy stress the importance of concordance. Principles of epilepsy medication: start a low dose. Increase the dose until the fits are controlled or side effects occur. Use a monotherapy. Two drugs increase the toxicity and side effects and offer no benefits over the monotherapy for 90% of the patients. Prescribed by brand name. Changing the brand carries a 10% risk of worsening of seizure control. So all the anti-epileptic drugs you have to prescribe by brand name. Type of epilepsy: absent seizures, you give ethosuximide, first line; sodium valproate, lamotrigine and clonazepam are second line. Myoclonic seizures, sodium valproate is first line. Tonic-clonic seizures, sodium valproate is first line. Carbamazepine and lamotrigine can be given. Depends. Sodium valproate, tonic-clonic seizures. Uh, we will see the discussion. Partial seizures or secondary generalized seizures, again sodium valproate, carbamazepine, lamotrigine. These are the drugs. Sodium valproate is given without any restriction to males, and in females lamotrigine is the drug of choice. Adult starting dose 500 milligrams of ethosuximide. Incremental dose 250 milligrams per day at weekly intervals. Usual daily dose 1 to 1.5 grams OD. Common important side effects of ethosuximide: blood dyscrasias, sedation, nausea, vomiting, dizziness, and ataxia. Ethosuximide. Sodium valproate is teratogenic. Avoid prescribing female of childbearing age. If essential, ensure that female is fully informed of potential risk and has reliable contraception. Starting dose of sodium valproate. Sodium valproate is used in every type of seizures: absence, myoclonic, tonic-clonic, partial generalized. But then its use as a first line or a second choice of drug will depend upon the gender as well as the type of seizure. Adult starting dose is 300 milligrams BD, 200 milligrams incremental dose at per day at 3-day intervals. Usual daily dose is 500 milligrams 1 gram BD. Common important side effects: teratogenic, pancreatitis, liver toxicity, blood dyscrasias, sedation, tremor, weight gain, hair thinning, ankle swelling. So pancreatitis is an important side effect of sodium valproate. Liver toxicity, again blood dyscrasias, sedation, tremor, weight gain, hair thinning, ankle swelling. Carbamazepine is used in tonic-clonic and partial generalized seizures. 100 to 200 milligrams OD or BD. 100 milligrams per day at weekly intervals is the incremental dose. if there is no symptom control. Usual daily dose is 200 to 1200 milligrams. Again, it causes blood dyscrasias, rash, liver toxicity, nausea, sedation, diplopia, dizziness, fluid retention, and decrease in sodium. So, hyponatremia. Carbamazepine causes hyponatremia, diplopia, liver toxicity, of course, and blood dyscrasias. Lamotrigine. So, absence seizures, used in absence seizures, tonic-clonic seizures, and partial generalized seizures. 25 milligrams OD for 2 weeks. From the starting dose to 50 milligrams OD for 2 weeks, then increase by 50 milligrams per day at weekly intervals. So 100 to 200 milligrams is the usual daily dose. Blood dyscrasias, rash, fever, influenza-like symptoms, drowsiness, worsening of seizure control. So again, there's a rash with carbamazepine, a rash with lamotrigine. Okay, clonazepam. Again, it's used in absence seizures and myoclonic seizures. 1 milligram nocte for 4 days. Increase according to response over 2 to 4 weeks. 4 to 8 milligrams nocte is the usual daily dose. Drowsiness, fatigue, amnesia, confusion, restlessness, muscle hypotonia, coordination problems, dependence, and withdrawal. Dependence is main for benzodiazepine like drugs. So monitor the urea and electrolytes at regular intervals, at regular review. Where is number 2? Okay. Then starting dose is different if used in association with other antiepileptics. That's for lamotrigine. The starting dose is different if it's used in association with other antiepileptics. If it's used as a second drug. Number 4 is here liver toxicity with sodium valproate. Warn about symptoms of liver disease. Check the LFTs soon after starting and at reviews. And 5. This is blood dyscrasias associated with ethosuximide, sodium valproate, carbamazepine, lamotrigine. So all 4 drugs are causing blood dyscrasia. So check the FBC if there is bruising, mouth ulcers, symptoms of infection like sore throat or fevers. You will go to the next page. 550 muscle disorders. Symptoms: muscle weakness and fatigability, pain at rest suggests inflammation, pain on exercise, ischemia or metabolic myopathy. Signs: look for associated systemic disease, myotonia, delayed muscular relaxation after contraction, example difficulty to let go after gripping something, that is myotonia, local muscular tenderness or muscle firmness, firm muscles, may be due to infiltration of the muscle with a connective tissue or fat. Fasciculations, spontaneous, irregular and brief contractions of a part of the muscle suggest a lower motor neuron disease or motor neuron disease. Lumps, tumors are rare. Lumps may be due to a tendon rupture or a hematoma or herniation of muscle through the fascia. Muscular dystrophies, a group of genetic disorders characterized by progressive degeneration and weakness of some muscle groups. Dystrophia myotonica is an autosomal dominant inheritance. Abnormal DMPK gene on chromosome 19 presents at any age. Symptoms vary from mild to severe and may include dystrophia myotonica. Symptoms include muscle symptoms, weakness and myotonia, particularly involving the face, the eyelids, the jaw, neck, forearms, hands, lower legs, and feet. Can affect the speech and results in lack of facial expression. And result in speech problems, muscle symptoms. Respiratory symptoms. Weakness of the respiratory muscles, poor nighttime sleep, daytime sleepiness, headaches and difficulty in walking, aspiration, recurrent chest infections. Respiratory symptoms, weakness of respiratory muscles, poor nighttime sleep, daytime sleepiness, headaches, difficulty in waking up, aspiration, recurrent chest infections. Eye symptoms, dystrophia myotonica, cataract may be the only problem, and ptosis. Reproductive problems, infertility as a result of atrophy of the testes and problems in labor due to uterine muscle weakness. Learning difficulty and behavioral problems, digestive symptoms, swallowing difficulty, abdominal pain, constipation or diarrhea, gallstones, cardiac arrhythmias, annual ECG is advisable, endocrine abnormalities, diabetes mellitus, anesthetic problems, pre-warn the anesthetist or surgeon prior to surgery. Prognosis is variable depending on the severity of symptoms. Refer to confirmed diagnosis and for advice on management or genetic counseling. Dystrophia myotonica. Muscle symptoms, respiratory symptoms, eye symptoms, reproductive symptoms, learning difficulty, digestive symptoms, cardiac arrhythmias, endocrine abnormalities. Again, anesthesia problems will be there. And it's an autosomal dominant inheritance because it's a structural problem, right? Duchenne muscular dystrophy is a sex-linked recessive, whereas Duchenne muscular dystrophy is a sex-linked recessive inheritance, means almost always confined to the boys. So sex-linked, X-linked recessive, confined to the boys. Boys will have the disease. Girls will be the carriers. 30% of cases are due to spontaneous mutation. Investigation shows markedly increased creatinine kinase more than 40% times the normal. Markedly increased creatinine kinase more than 40 times the normal. Presents typically at 4 years with progressively clumsy walking. Poor fellows, 4 years, clumsy walking. Few survive to more than 20 years. Refer to confirmed diagnosis and ongoing specialist support. Genetic counseling is important. Toxic myopathies. Certain drugs can cause myopathy, including alcohol, labetalol, cholesterol lowering drugs like statins, steroids, chloroquine, zidovudine, vincristine, cyclosporin, cocaine, heroin, and PCP. I don't know what is PCP. Management. Stop the implicated drug immediately. If symptoms do not resolve, refer for confirmation of diagnosis and management advice. Acquired myopathy of late onset. Often a manifestation of systemic disease like thyroid disease, especially hyperthyroidism, carcinoma, Cushing's disease. Investigate to find out the cause. Treat the cause if found, otherwise refer for further investigation. Polymyositis. Insidious symmetrical proximal muscle weakness due to muscle inflammation, dysphagia and dysphonia or respiratory muscle weakness may follow. 25% have a purple rash on the cheeks, eyelids and other sun-exposed areas like dermatomyositis plus a nail fold erythema. Creatinine kinase levels are increased associated with malignancy in 10% of the patients. More than 40 years, you refer. In case you have a polymyositis patient more than 40 years of age, refer them because that may be associated with the malignancy. So muscle weakness, proximal, dysphagia, dysphonia or respiratory muscle weakness will follow. And 25% have a purple rash on the cheeks, eyelids and other sun exposed areas, which is called dermatomyositis. So dermatomyositis is associated with malignancies. So you need to refer. Poliomyelitis. Acute polio spread. Acute polio spread. Droplet of fecal or oral. Spread is by droplet infection or fecal-oral route. Incubation is 7 days. Presence with 2 days flu-like prodrome, then fever, tachycardia, headache, vomiting, stiff neck and unilateral tremor. Pre-paralytic stage. 65% who experience the paralytic stage go on to develop paralysis, myalgia, lower motor neuron signs plus respiratory failure. Management. Supportive. Admit to the hospital. Less than 10% those developing paralysis die. Permanent disability may result. Prevention. Primary immunization in babies and children less than 10 years. 3 doses of the 6-part vaccine. DTaP. IPV, Hib and hepatitis B. Protecting against polio, diphtheria, whooping cough, tetanus, Haemophilus influenza type B, and hepatitis B. Each 1 month apart, usually at 2, 3, and 4 months. If schedule is disrupted, resume when stopped. Booster doses in children: 1 dose 4-part vaccine, DTaP and IPV, protecting against polio, diphtheria, whooping cough, and tetanus more than 3 years. After one course, usually preschool, and another dose 3-part vaccine, diphtheria, tetanus, and IPV against tetanus, diphtheria, and polio 10 years later, that is age 13 to 18 years, you give a Tdap. Primary immunization in children more than 10 years and adults. 3 doses of 3-part vaccine Tdap, each TD and IPV, TD and tetanus, diphtheria and IPV, that is 3-part vaccine, each 1 month apart. So 3 doses. So initially if the people have not received an immunization, the children or adults, more than 10 years. If they did not receive primary immunization, they should be given 3 doses 1 month apart. Give a booster dose after 3 years and 10 years. Booster doses for travel, not required unless at special risk. Example, traveling to an endemic or epidemic area or healthcare workers. Boosters of TD and IPV are given every 10 years. Okay, for healthcare workers, you have to take a booster every 10 years. Late effects of polio: 20 to 30 years after initial infection, some patients develop new symptoms often triggered by a period of immobilization. Increased muscle weakness and fatigue, pain in the muscles and joints, respiratory difficulties, particularly in those who spend some time in an iron lung ventilator, may present with symptoms relating to sleep. Once other causes are excluded, treatment is supportive. Motor neuron disease 552, myasthenia gravis or Lambert-Eaton syndrome 518. We have already read those. 552 other neurological syndromes. Von Reckling-Husson disease or type 1 neurofibromatosis NF1 or von Reckling-Husson disease. Autosomal dominant, of course, neurofibromatosis is autosomal dominant. Criteria for diagnosis: 2 of the following should be present: more than 6 Cafe-Lewis spots, flat coffee colored patches of skin seen in the first year of life, more increase in number and size with age, more than 5 millimeters prepubertal or more than 15 millimeters postpubertal diameter of the spots. That is, more than 6 of them should be present in the first year of life. More than 2 neurofibromas, dermal neurofibromas, small violaceous skin nodules which appear after puberty, nodular neurofibromas, subcutaneous firm nodules arising from nerve trunks may cause paresthesia if compressed, or a plexiform neurofibroma which appears as a large subcutaneous swelling. Freckling in the axilla, groin, neck base and submammary area. Women: axilla, groin, neck base and submammary area in women, present by the age of 10 years. More than 2 leash nodules of the iris only visible with a slit lamp. Distinctive bony abnormalities specific to NF1, that is sphenoid dysplasia, and first degree relative with an neurofibromatosis type 1, that is 1 point. So any 2 of these should be present for a diagnosis of NF1. Either you have Cafe-Lewis spots or neurofibromas or freckling in the axilla, groin, neck base, or leash nodules, or bony abnormality like sphenoid dysplasia, or a first degree relative with NF1. Management: ongoing specialist management is essential. Complications affect 1 in 3 patients: mild learning disability, short stature, macrocephaly, nerve root compressions by fibromas, GI bleeding or obstruction, cystic bone lesions, scoliosis, pseudoarthritis, increase in BP due to renal artery stenosis of pheochromocytoma, okay, malignancy, optic gliomas or sarcomatous changes of neurofibroma, epilepsy, slight increase in complication of epilepsy. So, blood pressure is raised in neurofibroma. Why? Because there can be renal artery stenosis or a pheochromocytoma which is associated with NF1 syndromes. Type of neurofibromatosis: type 2 neurofibromatosis NF2, much rarer than type 1. Both are autosomal dominant inheritance. Diagnosis: one of Bilateral vestibular schwannoma should be present. Acoustic neuroma, sensory neural hearing loss, vertigo plus tinnitus, or first degree relative with NF2 and either unilateral vestibular schwannoma or a more than one neurofibroma, meningioma, glioma, schwannoma, or juvenile cataract. More than one of the following: neurofibroma, meningioma, glioma, schwannoma, or a juvenile cataract, plus a unilateral vestibular schwannoma in a first degree and a first degree relative with NF2. So that is the diagnosis. Or bilateral vestibular schwannoma is diagnostic of neurofibromatosis type 2. Management: screen at-risk patient with annual hearing test. Once the diagnosis is made, specialist neurosurgical management is needed. Complications: schwannomas of other cranial nerves, dorsal nerve roots, or peripheral nerves, meningioma, or other gliomas are less common. Ekbom syndrome or restless leg syndrome. The patient, who is usually in bed, is seized by an irresistible desire to move his legs in a repetitive way, accompanied by an unpleasant sensation deep in the legs. Sleep disturbance is common, as is positive family history. Causes is unknown. Management: exclude the drug causes. Common culprits are beta blockers, H2 agonists, neuroleptics, lithium, TCS, and anticonvulsants. Exclude peripheral neuropathy or ischemic rest pain. Iron deficiency, with or without anemia, is associated 1 in 3 sufferers, so check FBC and serum ferritin levels. Restless leg syndrome associated with iron deficiency, peripheral neuropathy, ischemic rest pain, drug causes. Also check urea electrolytes, creatinine, eGFR, fasting blood glucose, and thyroid function test. Try non-drug measures first: reassurance, information, walking or stretching, warmth, relaxation exercises, and massage. Drugs: dopamine agonists are often effective. Example: ropinirole and pramipexole. Ropinirole or pramipexole. Refer if symptoms are severe or diagnosis is in doubt. So ropinirole and pramipexole, which are dopamine agonists, are used in Parkinsonism as well as in restless leg syndrome. Wernicke's encephalopathy. Thiamine deficiency causing nystagmus, ophthalmoplegia, and ataxia. Other eye signs, example, ptosis, abnormal pupillary reactions, and altered consciousness or confusion may also occur. Consider in any patient with symptoms and a history of alcohol misuse. Nystagmus, ophthalmoplegia, and ataxia. Management: refer for confirmation of diagnosis. Meanwhile, start a thiamine 200 to 300 milligrams OD per orally to prevent irreversible Korsakoff syndrome or Korsakoff psychosis. Severe cases admit as a medical emergency. Korsakoff syndrome: decrease the ability to acquire new memories, may follow Wernicke's encephalopathy, and is due to thiamine deficiency. Confabulation to fill the gaps in the memory is a feature. Gillis de la Torre syndrome. Gillis de la Torre syndrome, 889, we will read there. Huntington's disease or chorea is an autosomal dominant again. Testing can identify affected individuals before the symptoms occur. Preconceptual and antenatal testing is available and should be offered to any couple with a family history or on either the mother or the father side, because it's autosomal dominant. Presence with movement abnormalities, example hemichorea and rigidity and dementia. Memory is relatively spared compared to cognition. Refer to neurology for diagnosis and expert advice, and to genetics for discussion of gene testing. Friedreich's ataxia. The most common inherited ataxia, however, it is autosomal recessive. So there are two ataxias that are autosomal recessive inheritance, whereas other structural conditions are autosomal dominant, like Huntington's chorea. Friedreich's ataxia is one of the autosomal recessive ataxias. Prevalence 1 in 50,000, presence in adolescents with progressive gait and limb ataxia, loss of proprioception, pyramidal weakness, and dysarthria, presenting in adolescent age group. Extra neurological involvement includes heterotrophic cardiomyopathy, most patients, and diabetes mellitus. Treatment is supportive. Most patients become chair-borne within 15 years and die in the fourth or fifth decade from cardiac or pulmonary complications. Neurological rehabilitation problems. General principles of rehabilitation 196. Fatigue. Consider and treat the factors that might be responsible for problems in neurological rehabilitation, like depression, disturbed sleep, chronic pain, and poor nutrition. Action: review and support, diet and medication. Encourage graded aerobic exercise. Consider a trial of amantadine 200 milligrams per day to improve the symptoms. Depression and anxiety are common. Diagnosis can be difficult. Use nice depression screening questions. Any positive response should prompt further assessment for depression. Talk about the impact of the illness on lifestyle. Jointly identify where positive changes could be made. Example, referral to daycare to widen the social contact. Consider referral for counseling or to a self-help group. Consider antidepressant medication or a referral to psychiatric services. So most of the neurological conditions, there is a component of depression and anxiety which should be tackled appropriately. Emotionalism. If the patient cries or laughs with minimal provocation, consider emotionalism, impairment of control of crying. Reassure. Sexual and personal relationships problems are common. On useful information sheets are available at the website. Communication problems, speech therapy assessment is vital. Consider support via dysphasia groups and communication aids. Example, simple pointing board. Take advice from speech therapy and OT. Poor vision. Refer to an optician in the first instance. If corrected vision is still poor, refer for ophthalmology review. Respiratory infections. Common. Treat with antibiotics unless terminal stages of disease. Advise pneumococcal or influenza vaccination as appropriate. Respiratory infections. Flu vaccine may be contraindicated for some patients with multiple sclerosis or disease modifying therapy. Yeah, multiple sclerosis, there is a disease modifying therapy, and flu vaccine may be contraindicated in some patients with multiple sclerosis on that disease modifying therapy. Not always they are on DMARDs, and initially the drug of choice is prednisolone, steroids, and then in remission phase they can be put on DMARDs, and that time the flu vaccine is contraindicated. Venous thromboembolism. Common but DMRDs, yes. Venous thromboembolism, common but clinically apparent in less than 5%. Ensure adequate hydration, encourage mobility, consider use of compression stockings if immobile. Prophylactic anticoagulation does not improve the outcome in neurological conditions. New symptoms or limitations. Consider it is due to an unrelated disease. Change in bowel habit in someone who had a stroke might indicate bowel cancer. Is it due to an incidental infection like UTI or chest infection? Is it due to a relapse, acute relapse in MS, TIA, or further stroke? Is it due to a side effect of treatment like acute confusion, involuntary movements, or an on-off effect in patients with PD? Is it a part of gradual progression in MS, MND, brain tumor? Treat any cause of deterioration identified. If no cause is found, consider re-referring to a specialist review or referring to multidisciplinary rehabilitation team involved in with the patient. Motor impairment. Aim to maintain physical independence. Involve physiotherapy or OT. Often ask for oriented approach is Often a task oriented approach is used, like learning how to dress. Can also supply or advise aids on and appliances. Example, hook and loop fasteners, wheelchairs, adapted cutlery, etc. Refer to social services OT assessment if aids, equipment, or adaptations are needed for the home. Refer for home care services as necessary. Give information about driving or employment when appropriate. Spasticity plus or minus muscle and joint contractures. Treat with physiotherapy, usually involving exercise plus splinting plus drugs. Antispasticity drugs include dantrolone, baclofen, dizanidine, gabapentin in divided doses. Botulinum toxin can be directed at specific muscles. Refer via a specialist rehabilitation team. Pain. Most pain arises from decreased mobility. Other causes include premorbid diseases, example osteoarthritis, central pain due to neurological damage, and neuropathic pain. Chronic pain, especially the central pain, may respond to TCS. Central pain may respond to tricyclic antidepressants. Peripheral pain may respond to simple analgesia or physiotherapy. Other options are TENS, transcutaneous, transcutaneous electrical nerve stimulation, and local joint injection. A cannabinoid is now available as an oromucosal spray, that is Sativex, for relief of pain and muscle spasm in multiple sclerosis on patient specialist prescription only. Refer patient with intractable pain to specialist pain clinics. Avoid long-term opioids or benzodiazepines. Bladder problems. UTI if suspected, check urine dipstick and send MSU for microscopy, culture sensitivity and start antibiotics. If more than 3 proven UTIs in 1 year, refer for specialist incontinence service or urology for further assessment. Incontinence. Page 424. If urgency, modify the environment. Example, provide a commode, try anticholinergics like tolteridone 2 milligrams BD or oxybutynin 5 milligrams TDS. That is for urinary incontinence. If not settling, refer for specialist assessment. Nocturia. Desmopressin 100 to 400 micrograms per oral, 10 to 40 micrograms intranasally may help. Bowel problems. Dysphagia. Common fluids are more difficult to swallow than semisolids. Formal assessment by trained staff is essential. Feeding through nasogastric tube or percutaneous endoscopic gastrostomy PEG may be needed. So percutaneous endoscopic gastrostomy or PEG. Mhm. Feeding through nasogastric tube or a percutaneous endoscopic gastrostomy PEG may be needed for long-term or short-term treatment in terminal disease, example in motor neuron disease. Weigh the provision of nutrition against a prolonged poor quality life. Constipation. Difficulty with defecation or bowel opening less than 2 times in a week. Increase the fluid intake, increase the fiber in the diet. If no improvement, use a peroral laxative plus regular suppositories or enemas. Incontinence. Exclude overflow due to constipation. Skin breakdown. Prevented by positioning, immobilizing, good skin care, management of incontinence, and pressure relieving aids like special mattress or cushions. Involve community nursing services. Neurological assessment scales. So, doctors, that's all for today. We will continue tomorrow from page number 556, Neurological Assessment Scales. Thank you. Have a good day.